Hi, everybody. Thank you for joining today's webinar. Dr. Deva Sharma will now begin the program.
Good afternoon, everyone, and welcome to today's program, The Influence of Sex Hormones and Menses on Sickle Cell Pain in Women. My name is Dr. Deva Sharma. I am an assistant professor of hematology, oncology, and transfusion medicine at Vanderbilt University Medical Center. I will be moderating today's program and am joined by my excellent mentee, Dr. Zachary Ramsay. He is a research fellow at the University of the West Indies in Kingston, Jamaica. I and our entire team are exceptionally proud of his work. He is leading one of the largest cohort studies in the world of women with menstruation-related sickle cell pain. And it's a pleasure to be able to be present and support his very meaningful work. About the Foundation for Women and Girls with Blood Disorders has a mission to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the Foundation has focused on realizing its vision through these objectives, as you can see displayed. A couple of housekeeping items. To ensure the best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Dr. Ramsay and myself at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we will address those questions during the Q&A session at the end of today's presentation. The next few slides detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by Cinemed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME/CE credits for the program after its conclusion. This activity is being provided independent of any industry support. And these are the learning objectives for today's events, which I will sort of let you all review and read. We're going to discuss the association between the levels of sex hormones, estradiol, progesterone, testosterone, and neuropathic pain and chronic pain in women with sickle cell disease. We will also describe the associations between sex hormones with thermal and pressure pain thresholds and interpret changes in quantitative sensory testing during the follicular and luteal phases of the menstrual cycle. And we have the following disclosures to share. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose. Next slide. All attendees will receive an email an hour after the program's conclusion with the evaluation and this link to claim your 1 credit hour. The accreditation overview is also available as a handout. Before we begin, we would like to do a quick poll to see how many people are joining us today with others. Please take a moment to answer the poll question on your screen. Excellent. Thank you all so much. We would also like to ask a few questions to assess your knowledge before Dr. Ramsay's presentation today. In studies with women without sickle cell disease, which of the following is usually found to be anti-nociceptive? A, estradiol, B, testosterone, C, progesterone, or D, follicular stimulating hormone? Excellent, thank you. Our next question is a true or false question. Women with sickle cell disease in Jamaica have been found to be less sensitive to pain, and this has been associated with lower quality of life. True or false? Excellent. Our third question, estradiol typically interacts with the nociceptive system through the following, and you can select more than one option. A, altering the emotional regulation network and resulting in a dissociation of pain intensity and pain unpleasantness. B, acts directly as a neurotransmitter. C, inflammatory response modulation. D, initiation of cellular signaling pathways, such as mitogen-activated protein kinases, resulting in activation or inhibition of other nociceptive receptors. Excellent. And for our very last polling question here, progesterone typically interacts with the nociceptive system through the following. And again, you can select more than one option. A, altering the emotional regulation network and resulting in a dissociation of pain intensity and pain unpleasantness. B, acts directly as a neurotransmitter. C, inflammatory response modulation. And D, altering the pH levels in the bloodstream. Okay, thank you all for your responses. I will now turn the slides over to Dr. Ramsay for his presentation, which we are all very much looking forward to.
Hi, good morning, everyone. Thanks for the great introduction, and it definitely is a pleasure to present here. And of course, many thanks to the Foundation for Women and Girls with Blood Disorders for their support, and not only in carrying out the research, but in advancing care and evidence-based medicine for women with sickle cell disease and other related disorders. Now, as has been said, I'm going to be presenting on the pathophysiology of pain and menses, and we're going to be talking about a study that's being done in Kingston, Jamaica at the Sickle Cell Unit. Okay, so initially, this was back in 2019, we conducted a study among both males and females, 257, to assess neuropathic pain. Now, we used quantitative sensory testing, the pain detect and ask me questionnaires, and what we essentially found was that the odds of neuropathic pain were actually higher among females compared to males. Now, furthermore, we also found that the odds of apart from the odds of neuropathic pain being higher among females, we also found that unemployed females actually had a worse related quality of life related to their pain impact. So we could see that women were more sensitive to pain, they were being affected more, and that it was negatively affecting their quality of life. When we looked on quantitative sensory testing, we also found that the women were more sensitive to both temperature and pressure pain stimuli at both the hands and the feet. So that's what you're seeing here. This is temperature, and we can see that at the feet and the hands, they have lower sensitivities to these stimuli, suggesting that they are more sensitive and essentially they feel pain faster. Now, there were other studies that supported our need to do this study. So Dr. Sharma, who just spoke, she conducted a study among women with sickle cell disease, and using questionnaires such as a sickle cell disease pain burden interview in youth and the menstrual symptom questionnaire that looks at dysmenorrhea, she found that as many as 1/3 of the patients had acute vaso-occlusive crisis pain that was associated with their menses, and that among those patients, about half of them, it occurred 0 to 7 days before the start of their menses. In fact, she found that when they looked at it in multivariate regression models, dysmenorrhea was associated with this cyclical pain. And that's something we'll discuss a little more. Now, there were some other studies that discussed these findings. So another study had found that 37% of women with sickle cell disease had definitive cyclical pain crises that were associated with their menses. And additionally, we found that giving hormonal contraceptives, such as Depo-Provera, can result in a decreased rate of vaso-occlusive crises. Now, we understand that definitely there's a hormonal link between pain and, the menses. We have some evidence for that, but we wanted to investigate it further, get further details, and also to assess some other mechanisms that could be involved. So, as I mentioned, we know that there's a hormonal link. We saw that there's some evidence, but we also know that estradiol, testosterone, and progesterone, these are known to have important roles in nociception in women without sickle cell disease. But there are other things to consider, such as nitric oxide, prostaglandins, and inflammation, and particularly because these not only interact with the nociceptive system, but also with the vaso-occlusive crisis process in sickle cell disease, as well as with the nociceptive system itself. Now, there are also a number of psychosocial factors, such as coping and catastrophizing, that are different between men and women, and these have also been found to account for some of the differences in pain that we've seen. But we're going to talk a little bit more about the first three. Now, as I've mentioned, when it comes to studies in women without sickle cell disease, we have found that in general, testosterone tends to be anti-nociceptive, whereas estradiol and progesterone tend to have anti-nociceptive and pro-nociceptive effects. And the findings really differ in different studies for a number of different reasons, which we'll talk about. So the relationships between these hormones and pain, they are very complex. So for one, they are sex dependent. So the effect of estradiol on pain in men differs from how it may affect women. And of course, that effect is furthermore individualized. It does vary among different cyclical painful conditions. So they found that decreasing estradiol and furthermore obliterating it has an opposite effect in migraine than it has in IBS. And they've also found that basically under different experimental conditions, you may find different findings. Now, as I mentioned, and we'll get more into that as I go along. So this is just looking, this is a meta-analysis, and it's looking on a number of different studies that were conducted to assess pain sensitivity using quantitative sensory testing at different phases of the menstrual cycle. So that's what we're seeing up here. These are 4 studies. For this particular measurement, they're looking at the pain intensity ratings to pressure. The solid lines represent a higher sensitivity. The dashed line represents a lower sensitivity, and where we have this bar with 2 lines, it shows that there's no significant difference. But just to show, on the top, you can see that among those 4 different lines, first of all, it varies at the time at which they were conducting these measurements. And that's why it kind of makes it difficult to come up with these conclusive statements. But we can see that sensitivity was lower, tended to be lower towards the luteal phase and tended to be higher towards the earlier stages of the menstrual cycle. This graph similarly looks on it in a similar way, but we're looking on pain thresholds to electrical stimulation. Again, you can see the differences in the study methodology and why that makes it hard to come up with conclusive statements. But again, we can see a similar trend that pain sensitivity tends to be lower in the later phases and higher in the earlier phases of the menstrual cycle. And again, this is we're seeing a similar trend here when we look at pain thresholds to pressure. So We understand that definitely pain sensitivity changes throughout the menstrual cycle, and that's one of our goals, to try and assess how that looks within sickle cell disease. Now, one of the reasons why that may be is because that we know that these hormones, they have a direct effect on the nociceptive system. And basically, that's the pain system within the central nervous system. Now, estrogens and androgens, we know that they are generated throughout the central nervous system, and they circulate throughout the central nervous system. And that furthermore, their receptors, so androgen receptors, estrogen receptors, they are expressed throughout the central nervous system. Aromatase, which is an enzyme that converts testosterone to estradiol, is also expressed throughout the CNS. Now, we've seen this in animal studies. So for example, the periaqueductal gray, which is the main pain inhibitory area in the brain, it is known to express estrogen receptor alpha and androgen receptors, and that there are more androgen receptors expressed in males, so we can see that that may be accounting for some of the differences. We've also seen that giving estradiol intrathecally and intraperitoneally resulted in a profound increase in pain sensitivity, and that giving an aromatase inhibitor resulted in the opposite effect. So we can see again that, you know, there's a lot of activity with these sex hormones directly in the central nervous system and around these specific pain-specific areas. Furthermore, they found that aromatase is expressed in the spinal cord, dorsal horn, and particular areas in the medulla that are known to contain inhibitory interneuron markers. In more recent studies, we found that in high estrogen states, women tend to display more mu opioid receptors and have greater activation of endogenous opioid transmission during pain. And progesterone has also found to be neuroprotective, and that it positively modulates the GABA receptor. Estrogen has also been found to have strong effects on the serotonin system. Now, in a more recent study, apart from those direct effects on the nociceptive system, they've also found that it is also important in the emotional regulation of pain. Now, what they did was that basically in lower progesterone states, or even in normal progesterone states, they found that when you apply a painful stimulus, there is a strong correlation between the pain intensity and basically the unpleasantness that women feel from the pain. We would expect that, obviously, that as the pain gets more intense, your unpleasantness rating increases, and they found that it had a high correlation. But in high progesterone states, they found that women actually dissociate that unpleasantness from pain intensity, and that may be due to a decrease in functional connections of the emotional regulation network. They found that by looking on functional MRIs. So in addition to the direct effects of these hormones on all of the different receptors and all of the different receptors and pathways within the nociceptive system, they also affect the emotional regulation of pain. Now, there are several other complex potential mechanisms, and of course, we're hoping that we can explore them not only within this study, but within work that will follow. Now, essentially, on a cellular level, estrogen basically operates through ligands. So what that means is that activation of the estrogen receptor, it initiates different cellular signaling pathways, particularly mitogen activated protein kinases, and that will result in either the initiation or the inhibition of different receptors that play an important role in the nociceptive system. So for example, activation of the estrogen receptor can result in the upregulation of TRP channels, such as TRPV1, that has been implicated in the development of neuropathic pain in patients with sickle cell disease. So that's the TRP channel there. And as I said, this is basically the estrogen binding to the estrogen receptors and activating these cellular signaling pathways. So that's what's happening here. Other receptors are implicated, such as the NMDA receptor and GABA receptors. So that is essentially how estrogen operates. Now, in addition to that, as I mentioned, there's an important relationship between nitric oxide and these hormones. We already know about the role of nitric oxide in vaso-occlusive crises, but we've also found that estradiol and progesterone have been associated with an increase in nitric oxide production, and that progesterone has been associated with a decrease in nitric oxide bioavailability. They've also found that nitric oxide and its metabolites are higher in the follicular phase when compared to the luteal phase. Now, similarly, these hormones also interact with prostaglandins, and we know that in sickle cell disease, when patients have these vaso-occlusive crises, prostaglandins and the inflammatory cascade is an important part of not only initiating that process, but furthering it. And they have found that estradiol has been associated with a reduction in prostaglandin E2 when it is at a lower concentration, and that there's an increase in PGE2 when it's at a higher concentration. It's also been found to be reduced by total testosterone and to have varied effects after the depletion of estradiol. So there's a very complex relationship between prostaglandins and these different sex hormones. Now, within the menstrual cycle, they have actually found that there are higher concentrations of prostaglandin E2 in the plasma and on endometrial biopsy before and on the first day of menstruation in women with dysmenorrhea compared to those without. And it's this increase in prostaglandin that may also account for why it is that women with dysmenorrhea, those with sickle cell disease and dysmenorrhea, are found to have cyclical pain, as was found in Dr. Sharma's study. So it could be that this increase in the concentration of prostaglandins is contributing to that. Right, so as we can see, there are a lot of different complex relationships between these sex hormones, emotional regulation of pain, neurotransmitters within the nociceptive system, as well as nitric oxide, and additionally psychosocial and other factors. It's very complex, and we wanted to assess these different relationships among women with sickle cell disease. So I think Dr. Sharma read these objectives already, but basically the aim of the study is to determine the associations of levels of these different hormones with the severity and frequency of acute pain, as well as the presence of both neuropathic pain and chronic pain. Additionally, we wanted to look at the associations of these hormones with thermal and pressure pain thresholds measured by quantitative sensory testing, and then to determine the changes in these thresholds throughout different phases of the menstrual cycle. Now, these were our inclusion criteria. So we included women who were 18 years or older with sickle cell disease, and we ensured that they had normal vital signs, that they were screened low risk for COVID-19, in order to avoid certain potential confounders, such as women with having irregular menses, or if they would have, any abnormalities or anything that would change the normal physiology of their endocrine and HBG axis. We ensured to only include women who had regular menses, those who were not pregnant, if they had no prior history of a hysterectomy or oophorectomy, and if they did not have menopause or primary amenorrhea. We also excluded women who were on hormonal contraceptives currently or in the last 3 months. Now, this is just to show you the different measurements that we're doing in the study. So we're going to see women twice, once in the follicular phase and again in the luteal phase, ideally within the same cycle, but it depends on when they present to us in the clinic and we can decide. So if they present within the follicular phase, we will enroll them in the follicular phase and otherwise. Now, the 3 main outcomes are the pain detect questionnaire, which we used to assess for the presence of neuropathic pain and the presence of chronic pain. The Ask Me Pain episode, which assesses the frequency and severity of vaso-occlusive crises, and then quantitative sensory testing, which assesses the subjective perception of painful stimuli. Just to explain what quantitative sensory testing is, essentially, we attach a probe onto patients' hands or their feet, and the probe will supply some type of stimulus, whether it's pressure or it's heat or it's cold, and the patient has a button and they press it whenever they detect it or whenever it becomes painful, depending on the test that we're conducting. Now, of course, we did both of these at both phases, and in terms of our main independent variables that we're looking at, so of course we're trying to assess serum estradiol, serum total testosterone, and serum progesterone, and those were done at both phases as well. We also conducted a pregnancy test at each visit to ensure that they're not pregnant. We assessed depression and anxiety using the PHQ-9 and GAD-7. Dysmenorrhea and heavy menstrual bleeding were assessed using the menstrual symptom questionnaire and the menstrual bleeding questionnaire. And then we assessed other psychosocial and biological confounders using the Ask Me. Now, I know that it looks like a lot, but we're able to get it done within an hour, and it doesn't usually cause any issues. Now, we conducted the visits at specific time periods. This is based on a study that tried to assess basically the optimal time to measure each of these different hormones, and that was based on the periods within the menstrual cycle when they had the highest interpersonal and intrapersonal correlation. So those were basically days 9 to 11, ideal for testing estradiol, and the days 17 to 21, ideal for testing progesterone. So the visits for the follicular and the luteal phases had to fall within those time periods. We also conducted quantitative sensory testing according to standard protocol. Now, I'm showing you some preliminary findings. We have recruited up to 120, but at the time of this analysis, it was 94 patients. You can see that there was a mean age of 29. As many as 78% of patients were homozygous SS genotype. There was an average age of menarche of 14 years, average mean menstrual cycle length of 28 days, and a mean bleeding length of 4.9 days. Now, we can see here, we're just showing you the mean levels of each of the different hormones. So that's the estradiol, progesterone, and testosterone. And you can see that they did not significantly differ from the reference population. Using paired t-tests, we assessed to see if there was any difference in the levels of these different well, before I get there, we assessed. So here below that, you can see the different thresholds for quantitative sensory testing. So cold detection, heat pain at the forearm and the leg, and then trapezius pain for pressure stimuli. We compared the two, we compared the findings in the follicular and the luteal phase, and so far, based on paired t-tests, we can see that there's no difference in either of the two phases. Furthermore, based on some preliminary analyses, we have found that there's a significant relationship between estradiol and the mean lower limb pain threshold. This is in the follicular phase. And this is, of course, based on multivariate analyses, where you can see we control for other factors such as age, genotype, their depression levels, the amount of, quantitatively measuring the amount of heavy menstrual bleeding and dysmenorrhea that they have, as well as their BMI. So we can see this relationship here. So we can see that with increases in the level of estradiol, there is a lowering of the mean lower limb heat pain threshold. Basically, what that means is that as the estradiol gets higher, patients feel pain at a lower level, so they're becoming more sensitive. And that supports our previous hypothesis that estradiol is pronociceptive. So in summary, we saw that sex hormones basically have a very complex mechanism with pain in sickle cell disease. And their effects include through mechanisms such as through nitric oxide, prostaglandins, inflammation, and other very important mediators of vaso-occlusive crises. We've seen that these sex hormones, they have a number of very important functions in the central nervous system, particularly nociception. But we've also seen things such as the emotional regulation of pain, and we see that they can either promote chronic neuropathic pain or be neuroprotective. So this study that we're conducting, it aims to describe some of these complex relationships. And of course, we believe that it truly does have the potential to identify the rationale for new therapeutic targets. I should mention a limitation, which is that typically when we look on quantitative sensory testing data for studies, we use a reference population, and we are in the process of collecting data for a healthy reference population of Jamaicans. So these are preliminary analyses, and as we further it, we'll include that into our analysis. But I can tell you that the model that I presented, the finding is fairly robust, and it does hold up, through a number of different sensitivity analyses and using different covariates in the model and so on. So I just want to thank again the Foundation for Women and Girls with Blood Disorders, as well as the Sickle Cell Unit, the patients, the doctors, and the nurses, all for helping us to get the study done, particularly the study team, so Professor Asnani, Dr. Sharma, Professor Knight Madden, Dr. Campbell, Nurse Margaret Wisdom Phipps, and Dr. Chin. And also just like to briefly thank the following persons for the use of their figures, which were shown in the presentation. Thank you.
Thank you, Dr. Ramsay, for this excellent presentation. Again, I emphasize that this is the very largest, perhaps the largest cohort of women with sickle cell disease with a focus on menstruation and pain. Thank you very much. At this time, we will proceed with the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your control panel. So I'll start with a question for you, Dr. Ramsay. As you highlighted, the mechanisms of pain are sort of very complex in the literature, and sometimes, sex hormones can have dual effects, both on nociception and, have like pro and anti-nociceptive effects. Were the findings, first question is, were the findings in your preliminary data so far what you had expected?
Apologies, I was muted. Yes, so in the sense that we did expect that estradiol would have been pronociceptive. So we have found that, yes, we did expect that.
And then, based on these results of your preliminary data, what would you anticipate or foresee are your sort of next steps?
Well, it would be interesting to identify particular profiles of women who, are more likely to have not just cyclical pain, but pain that's influenced by hormones in a particular way. And then when we identify those women, we may be able to assess things like nitric oxide, prostaglandins, other biomarkers that may be involved in that whole pathway, so that we can understand it more in depth. I think that if we just took all women with sickle cell disease, yes, we have inclusion criteria, but we tried to assess those, more intricate relationships and biomarkers and mechanisms, we probably wouldn't have found an effect. So it's just important to identify, those individual women, that particular profile, and then try and assess things in more detail among them.
Excellent. We have a couple of questions. The first one is from Dr. Obadina. Dr. Obadina says, thanks for the wonderful presentation. Have there been similar assessments of pain and hormones in postmenopausal women with or without sickle cell disease?
Yes, there have. I have seen in particular a study that looked at, in fact, it's a study that we initially used to calculate the sample size, but a study that looked at lower back pain among postmenopausal women, and they essentially found, again, if I recall, that estradiol was hormonal-receptive, but it's something that has been looked at.
Excellent. Dr. Andrea Rowe has a comment and question for you. Dr. Rowe says, thank you so much for this presentation. I'm wondering what you make of the lack of difference between the follicular and luteal phase measurements in quantitative sensory testing, which I think would have been contrary to your hypothesis, correct?
Right. So as I mentioned, the quantitative sensory testing analysis is preliminary at this stage. I do think that when we include the reference values, things may change, and when we complete collecting the all the data. Additionally, I've used a very simplified method in looking at it there, in the sense that I used a paired t-test. So in further analyses, when we do have that reference data and I do some actual regression modeling with that part of it, that can account for some, confounders and so on, I think that we may find that there is going to be a difference. For now, it is preliminary analysis, though.
Excellent. We have another question from Dr. Leroy Melamed. Dr. Leroy Melamed says, super interesting, thank you. In your literature search, did you find differences across the reproductive lifespan? That was the first, there are multiple parts of this question, but that's the first part.
Differences in regards to what specifically?
I think differences in your pain outcomes, in the follicular and luteal phases across the reproductive lifespan. So I think in premenopausal women, for example, and postmenopausal women.
Mm-hmm. Well, I would start by saying that, of course, it hasn't really been studied among women with sickle cell disease. So if this is among women without sickle cell disease, from what I can recall, yes, there have been studies that look on, premenopausal and postmenopausal women. But from what I can recall, it still follows that trend that estradiol tends to be hormonal-receptive. I should mention that the other, sometimes the relationships are very mixed. But I think that tends to be the general trend. So the clinical picture in postmenopausal women tends to just be one of, where they have a low estradiol state.
And then the second piece of this question is, the following. Are the estradiol levels in your study controlled for age? For example, will older women have lower estradiol levels, and will that change their pain perception?
Right. So if I can go back, we did do a model. So within the regression model, we did control for age. And while controlling for age, that effect was still seen. So it was controlled for in that regression model that I showed you. What was the second part of the question again?
Yeah, the second part was, in these older women, with lower estradiol levels, does that change their pain perception?
Does it change their pain perception? Well, we've seen that the simple way, the only simple way I can answer that for you is that we have seen that there is an effect in multivariate models, and that we've controlled for age in that model. So we know that that effect is there while controlling for age. It would be interesting to look at, we have to mention, of course, that we don't have menopausal women in our study. So, that's something we may want to look at a later stage, to include women with amenorrhea and with menopause. But, that is a limitation. Those women are not included in our study. And it's simple. We wouldn't have found an effect if we had such a, wide study population. We had to control for some confounders. But the effect is there while controlling for age.
Excellent, and certainly a lot of future opportunities to expand this across the reproductive lifespan. There's a question from Dr. Susan Gray. In your opinion, should women with sickle cell disease be preferentially offered progestin-only birth control methods at this time?
I think it's a good option, and that well, I think that first of all, it comes down to assessing the patient individually. But I do think that, there does appear to be a lower side effect profile, and that they do appear to be effective in that regard. So I think it certainly is an option that you should consider using progesterone only contraceptives. And I know that in our clinic in Jamaica, that is the preferred option that we offer to patients.
Excellent. Dr. Mayan Leroy Melamed says, I appreciate your thorough answer. And Dr. Rowe has an additional comment, potentially for a future study. Dr. Rowe says, I wonder if measuring quantitative sensory testing during the perimenopausal period would have additional value. This time period would correlate more with the timing of perimenstrual vaso-occlusive events, so there may be even greater differences.
Mm-hmm. Sure, that's definitely something to think about.
Excellent. Are there any additional questions or comments from the audience?
If not, I think we are okay to go back to our polling questions for the knowledge gain.
All right. In studies with women without sickle cell disease, which of the following is usually found to be anti-nociceptive? Estradiol, testosterone, progesterone, or follicular stimulating hormone? All right, and there are our answers. Women with sickle cell disease in Jamaica have found to be less sensitive to pain, and this has been associated with low quality of life. True or false? Excellent. Everyone has a consensus. We're doing great. Next question, estradiol typically interacts with the nociceptive system through the following, and you can select more than one. Altering the emotional regulation network, acting directly as a neurotransmitter, inflammatory response modulation, and initiation of cellular signaling pathways. All right, excellent. And on to our last polling question. Progesterone typically interacts with the nociceptive system through the following. And again, you can select more than one. Altering the emotional regulation network, acting directly as a neurotransmitter, inflammatory response modulation, and initiation of cellular signaling pathways. Excellent. Everyone is doing a great job. And it looks like this is sort of all the time we have for questions, and I don't see any additional questions or comments. I just wanted to say, on behalf of the foundation, we would really like to extend an invitation to all those who are interested in learning more about women and girls with sickle cell disease, to join our Learning Action Network. And to do this, you can contact Carrie Funkhauser, and her email address is here. And more information about this excellent Learning Action Network can also be found on the Foundation's website. And again, this is a really great opportunity to collaborate with people from across the country to study this very underserved and understudied patient population, and to bridge gaps from both a clinical perspective and a research perspective. So I would encourage everyone to go to the website or contact Carrie to join if you're already not a member. And I just want to say again, thank you, Dr. Ramsay, for your excellent presentation today. It's really been a privilege to tackle this issue of pain associated with the menstrual cycle globally. And we really appreciate you, your team, the patients in Jamaica who participated and contributed this data. And I think it's really critical to bridge the knowledge gap in this area, which really has minimal published studies. So just want to really highlight how innovative and important your work is. And we all look forward to seeing more continued output from you and your team. Thank you so much. And the foundation is pleased to provide the foundation is pleased to provide this program at no cost to attendees. You will receive the evaluation following this program in your registration email in about an hour, along with the link to claim your continuing education certificate. A recording will also be made available by the end of the week, and all registrants will be informed once this is available. And again, thank you so much for your attendance today. We look forward to your future participation in foundation programs. We look forward to seeing you at our annual meeting and working with you through our Learning Action Network. So please feel free to email Carrie Funkhauser or go to our website, and we really look forward to seeing you again. Thank you all.